I wish my father would hear it, because when he started this meeting, the fact that we're talking about fixing meniscal root would blow his mind. And that's how the evolution of ROC and the evolution of orthopedics and Indian sports medicine has really become. So we're going to change and focus more now on the lateral side, the lateral root. As we know, the medial root, arthroscopically or anatomically, is married to the PCL. The lateral root is married to the posterolateral bundle of the ACL. Understanding those two things will help you do PCL reconstruction and not injuring the medial root. It will also help you do medial root repairs, and then it will also make you look a second longer at the lateral root when you're doing certainly primary ACL, but definitely secondary ACL. And we know, as we heard from Sabrina, that the medial root is an arthritis preventer. Actually, I think the medial root is one of the few procedures that we can do disease-modifying surgery in the knee. This can save. Aaron Critch has published multiple papers that if you fix a meniscal root, it can save a knee. There's almost nothing we do in orthopedics that is actually disease-modifying from arthritis. We bet 60 to 70% with the medial root. It's not 100%, but you can save a knee. The lateral root's it's not about contact mechanics as much, it's about stability. It's about ALRI. And we know from biomechanical studies that cutting the lateral meniscal roots will increase internal rotation in mid to moderate flexion. So to me, the secondary stabilizers, and we're going to talk a lot about the ALL, LLT, all these lateral stabilizers of the knee. The lateral meniscus is known to be the most important lateral stabilizer of the knee. So one of the rules that we have, eat when you can, sleep when you can, and always fix the lateral meniscus when you're doing ACL reconstruction. So I'm very aggressive about fixing this when I'm doing an ACL. Secondarily, there is some data emerging now that the lateral root also helps contact pressures. I don't believe this as much. I've seen a lot of lateral roots long-term and still have not an arthritic knee, but we have now emerging that there's a primary and a secondary effects of fixing the lateral root in the ACL deficient knee. So what's the clinical presentation? Well, we heard medial roots, a degenerative knee. The medial root's very common in the Indian knee. I do a lot of meniscus root repair on the Asian knee. The lateral root is more the eye see what the mind knows. You've missed a lot of lateral roots. And what's the number that you missed? It's about 7% for primary ACLs, and it goes up to 40% in revision ACLs. This is my favorite case when I'm doing a revision ACL, and the tunnels don't look so bad, the graft choice wasn't so bad. Why am I here? What's going on? Why did this graft fail? Well, I see a lateral root, and I get very excited. And then I am not doing LET, and we'll talk more about that. So let's go through my pearls. Pearl number one is that unlike the medial root, which is very easily diagnosed in MR, lateral root's a little more tricky. You got to really inspect it and you got to really probe it. And you can be tricked with the meniscofemoral ligaments because they can give you some secondary stabilization. But if you're doing an ACL revision, I'd say do a lateral root instead. It's all about, just like with the medial root, it's all about exposure. More fixation. You know, I clice the MCL every time on the medial root, and the lateral root, I don't clice the LCL, but I really get figure four, and I really, get more exposure. Realize, if you have a tight lateral compartment, the last thing you ever want to do is do an LET where you can over-constrain the lateral compartment. So if I have a tight lateral compartment, and I see a lateral root, I'm definitely fixing that lateral root on that revision ACL. We talked about tunnel guides. You can use an ACL tunnel guides, and now they're root-specific guides, and I actually like the root-specific guides because they wrap around the spines. You know, as we heard before, just like on the medial side, you want to decorticate, get good fixation, and good bony healing. The reason why roots heal, it's soft tissue to bone healing. The reason why menisci repairs don't always heal, because it's soft tissue to soft tissue, right? Soft tissue to bone is always superior to soft tissue to soft tissue. And as we heard about, I use, suture passing, I use luggage stitches. The thing that's unique about the lateral root is you want to create a unique tunnel. Medial roots, my hard operations, I do a medial root with an osteotomy. I don't want to hurt my sutures, my tunnel from that medial root. Lateral root, I got to get way medial to make my lateral root an independent tunnel for my ACL. On a small knee, there's not a lot of room, and I always put my camera into my tibial tunnel after I drill my lateral root to make sure I'm not hurting my lateral root. And I never pass my sutures down into my lateral root tunnel until after I confirm it's an independent tunnel. So what about some outcomes? Well, we actually know that if you ignore these, they're now saying there's increased instability, increased failures of ACL, and actually increased even arthritis. What about, re-rupture rate? Again, we're saying we're not really, these are small series, and they didn't see a huge difference in the re-rupture rate, but it's still emerging with the data coming out there. So here's a case when I was talking about a 25-year-old who had an ACL reconstruction with a hamstring autograft in 18, had a revision ACL with a BTB in 2020. This is as Freddie Fu, one of my teachers who passed away, would tell me, this patient is knee abuser. He abuses his knee too much. Third ACL, tough, on a 20-year-old kid. And you can see he's got a high-grade pivot. If I have a high-grade pivot, and this is something that Sachin has taught me and a lot of people here in India has taught me, right, you have to associate higher grade pivot with secondary stabilizer loss. You can't just do an ACL. And then another thing my dad would say is the definition of insanity is doing the same operation over and over again and expecting the same result. Right? You have to do something different. His collaterals are okay. His instability was okay. His alignment was okay. His tunnels looked okay. So I did, but you can see here there's a ghost sign of the lateral root, which you don't always see. So in this case, I did a revision ACL. In this case, I did an allograft. A lateral root repair. His lateral compartment was tight, so I didn't do an LET, although I have a very low threshold to do an LET, and I fixed his lateral root in a very similar fashion. So in conclusion, I think, a root tear is seeing you. You have to see it, really inspect the lateral root. The medial root's really easy to diagnose in MRI. Sometimes the lateral root is not. Have a high index of suspicion. If you're definitely doing an ACL revision, always fix the lateral root, and I would actually recommend fixing the lateral root on every primary ACL. Thank you very much.